Yeah, hi, good evening, good afternoon, everyone. Actually, it's a post-lunch session. I'll try to keep it as much understandable as possible. At the outset, thank you for the organizers and visionary to invite me here for this talk. As you can see, now coming apart from the surgical techniques, we'll come back to the bread and butter, as if I have to say that, for retina specialists here, because this session will mostly cater to them. But as the previous speakers have also told, that it's the responsibility of the anti-segment surgeons also to know about how to treat diabetic macular edema. So one of the topics here, of the hot topic of discussion here, is neovascular AMD and diabetic macular edema. But over the years, over the generations of anti-VEGFs which have been here and we have been using them in our daily day-to-day lives, there is something beyond what needs to be done now, because it's not just, as we all know, the anti-VEGF-A or the VEGF-A inhibition is what's required. Something which is there, which is more to be done in cases of these two important entities which comprise the bulk of cases for which anti-VEGFs are used, that is neovascular AMD and diabetic macular edema. Just to give you a small rough thought about how much will it increase in the next upcoming years, that is diabetic macular edema and neovascular AMD. As you can see here, it's almost expected to rise more than 40%, that's up to almost 47%, that is diabetic macular edema as well as neovascular AMD. Here, as you can see, neovascular AMD is almost expected to rise up to 47% in 2040. Now, what are the unmet needs? As you can see here written, that the need of frequent injections is the bottleneck where each and every patient suffers. Also, along with that, maybe missed clinical visits as well as the caregiver burden is always there. If I have to tell you about DME, again, this is not a secret. This is also we'll be able to tell or predict that this is not just a very small cause. As we had seen before, we are the diabetic capital here. So it's almost again expected to rise almost in more than one quarter, that is 25%. Here also the frequent injections as well as caregiver burden, multiple times visit is the bottleneck which we need to tackle. So now what next can be done? It's not just the anti-VEGFs which we have. The newer ones are the ones which are going to come up. So in those, a relatively new or the upcoming one is what we need to know about, or rather that's the focus of the talk here. That is, we all know, you must have guessed what I'm going to speak about, or the talk is centered to. As you can see, that it's not just the VEGF-A which is the culprit here. There are other factors also which cause the fluid accumulation here in these two set or cohort of patients, which is the ANG2 or the angiopoietin-2. So it causes vascular instability in the pathological tissues, as you can see on the slide here. So that is the main target which we need to see at. So the new antibody or the upcoming antibody, maybe the audience here across might be having much more experience than what I have. The name here is faricimab. It's a bispecific antibody that blocks both the angiopoietin-2 as well as the anti-VEGF-A. So that is the dual mechanism of action of faricimab. Now, why to see or why to consider this or the new upcoming or the rather more helpful for tackling these two entities is what we need to see or we need to look at. So kind of I'll be the devil's advocate here to vouch for faricimab. If I have to tell in terms of the language which we speak in each and every day today lives today, that is the biomarkers which are available to us. So OCT has been a help of very much help to us in tackling these two entities. So if we have to take a look at the biomarkers or how they change once we try and give this newer anti-VEGF option to patients, then what can happen? There is a greater reduction of fluid on the OCT in cases of AMD, as well as there is a greater resolution of the intraretinal fluid. This also acts upon decreasing or consolidating the height of the pigmented epithelial detachment in cases of neovascular AMD. If we have to look On the opposite side, where the majority-wise the angiopoietin 2 is the main culprit, so it causes inflammation as well as fibrosis. To tackle or to counteract that, we might have to give a agent which acts on ANG2. That is, it causes a greater reduction of the hyperreflective foci as well as epiretinal membrane. These are the two comparative data which I had to show you, so that it shows that in treatment naive as well as pre-treated eyes, it causes a better resolution in cases of faricimab. So this is kind of a take-home message for it. Greater drying period as well as a dual pathway is the way to go. This is one of the important comparative features for diabetic macular edema, if I have to tell you, related to faricimab. This also includes greater and faster drying as well as a proper having a structural and anatomical configuration. If we have to quickly tell you about the intraocular inflammation features, yes, there have been reports, but those are anecdotal, as well as maybe the retinal vasculitis can be one of the features. So if we look at various trials which have come across, the tenailucin as well as usamide and Rhine trials, yes, there is very less evidence of intraocular inflammation as compared to anti-VEGF or the newer anti-VEGF upcoming injections. So if I have to give you a checklist of what can be given as a provided as an option to our patients, yes, this is the checklist which needs to be ticked off for giving any anti-VEGF injections, whether it is efficacious, whether safe it is to give in patients, how improvement does it cause, how much improvement does it cause in cases of bioclinical or OCT biomarkers. So all that can be tackled with the help of one answer, which is faricimab. So these are the key takeaways from the presentation, that it is a dual acting anti-VEGF agent which can be very much helpful in cases of neovascular AMD as well as diabetic macular edema. With that, in my very much limited experience, yes, I have been using this newer and anti-VEGF, upcoming anti-VEGF injection. It has a very much faster and a drying or a rather smoothing drying effect in cases of these two entities. Thank you for your patient listening. I would like to ask just a quick question to the panelists, your experience in this.
Yet to try. So, would you consider it as a first line of therapy? Any other reservations where you would not consider this as first?
Yeah, no, there might be a few reservations because it might be a bit higher on the pocket of the patients, but if such patients, there might be in cases where the first line of agent is not available, or if the height of the PD in those cases are very much higher as compared to the ones which we see usually, then I can maybe refer to first, as in the first line agent in those cases. No such particular reservations as such in cases of giving maybe a new anti-VEGF agent. We give an option always to the patients that this is what is being upcoming, so that if they are able to afford it, yes, definitely we can give it.
If I may ask one more question in
Yeah,
the group, larger for people. If there is diabetic macular edema and a cataract, so would you recommend the anterior segment surgeons to first treat diabetic macular edema and then once it is stable for 1 or 2 months, then go ahead with cataract surgery? Or will you consider giving intravitreal injection along with cataract surgery and then follow up with a retina surgeon?
Yeah, so this is a good question. Maybe it might be coming up to many of the people sitting here. There are again two schools of thought of what can be done. One can be a combined surgery along with the injection. One can be first tackle of the edema and then you can go on to the cataract surgery. What we usually follow at our place is that maybe if it again depends upon the grade of the cataract as well as how much is the macular edema. As Dr. Ajit was telling us before, that you need to grade how much is the diabetic macular edema, whether it is a central involving or not. If it is a central involving, moderate to severe grade, and still if you think that it can be manageable without doing off the cataract, you can do. But if the cataract is significant enough, definitely if you do it along with the cataract surgery so that you can be able to tackle the posterior segment manifestations much better. So I would recommend maybe if you're having a significant amount of cataract, kindly do the cataract surgery along with the anti-VEGF injection. That would be my go-to choice.
Thank you.
Dr. Chandramohan sir, please come on to stage and give memento.
Vishal, please accept a small memento from senior retina surgeon Dr. Chandramohan sir. Meher, Miru Ren.